Good afternoon, good evening. I am Quinn Grundy. I'm an associate professor at the University of Toronto and director of the WHO Collaborating Center for Governance, Accountability, and Transparency in the Pharmaceutical Sector. I'm thrilled you can join us today for this 90-minute webinar. I'm joined here by my colleague, Deirdre DiMancesco, advisor in the Office of the Director, Health Products, Policies and Standards at the World Health Organization, who will be co-hosting with me today. In a moment, I'll turn it over to Deirdre to give some welcoming remarks as we are approaching the next round of the INC negotiations for an globally, international, legally binding plastics treaty. And I'm joined by some international experts today that are sharing their work in this space. So we will have some fantastic presentations and then hopefully ample room for some.
When you just went on mute.
Thank you. You can submit questions at any point, and we'll be able to address these at the end of the presentations. Let us know if you have any issues. You can message us as hosts in the chat. In the meantime, we'll ask you to stay muted and cameras on or off as you see fit. But if we have bandwidth issues, we'll ask you to turn them off at some point. Before I begin, though, I do want to acknowledge the land that I am working on today. For those of us here at the University of Toronto, in Toronto, we work and live on the traditional territories of the Haudenosaunee, Huron-Wendat, the Anishinaabeg peoples. This land is home to many diverse First Nations, Inuit, Métis people, and we honor their relationships with and stewardship of this land across generations. So as we engage in this discussion today, which is about the health of our planet and the health of our peoples, we strive to foster relationships that promote health and sustainability for all, and hope to work together towards a shared future that honors the lands for which we are all responsible. So to kick off this conversation and to set the stage for why we are having this here in the middle of July, early in the morning for those of us on the East Coast, late at night for those of us joining in Oceania, Deirdre is going to provide some remarks regarding the plastic treaty and the work that is ongoing. Over to you, Deirdre.
Thank you, Quinn. So first of all, my apologies. Our director of the department, Dr. Deus Mubangizi, was planning on joining today to provide some welcome remarks. This is a very busy time for WHO right now. We're undergoing a major restructuring process. So I work in Deus's office, and I'm part of the cross-cutting team, internal team in WHO on plastics. I represent our department in the team, and the team acts is representing WHO as an observer at the INC negotiations. So we've been attending the discussions since the start of the negotiations, and we will be there in about 10 days. So I'm pleased to welcome you to the webinar, and this is taking place on the margins of the international negotiations on a legally binding global treaty to end plastic pollution. The INC, which is the International Negotiating Committee, is convened by the United Nations Environmental Program, and they are working to negotiate the language of the treaty. The World Health Organization is advocating for an ambitious treaty to prevent plastic pollution due to its related risks to human health and the environment. Plastic pollution poses significant and growing risks to human health at every stage of its life cycle, from production and use to disposal and environmental contamination, especially impacting vulnerable populations. The risks are due to exposure to chemicals, to their additives in plastics, to micro and nanoplastic fibers, and this occurs during production, use, and disposal. In addition, Plastic waste in the environment can have serious impacts onto drainage, sanitation, and air quality if burned. Equally important is the use of fossil fuels in the production of plastics, which is a major contributor to global warming. Plastics are used widely in healthcare, and reducing their use is imperative to reduce the amount of waste generated by healthcare facilities. Many of these healthcare facilities are in countries that don't have the resources to manage waste properly. We know that they cannot manage the volumes of waste that are being generated. Given the widespread use of plastics in health products and their packaging, any change needs to ensure a balance between the potential negative impact on access to these health products versus the so the potential negative effects on access while protecting from risks and harms from plastics. When we talk about health products, we're talking about a category of products that include medicines, vaccines, medical devices, which includes in vitro diagnostics, assistive technology, and some other products like vector control products. And these products are used by every disease management strategy. They need access to those products for prevention, diagnosis, monitoring, treatment, cure, palliative care, and rehabilitation. And these products need to be safe, they need to be effective, of good quality, in addition to being affordable and appropriate to the users. And I make these statements because without access to health products, we cannot achieve the Sustainable Development Goals, and we put the health and lives of patients at risk. For example, without access to medical devices, many medical procedures from point of care COVID diagnosing, which many of us have used during the pandemic, to personal protective equipment, catheters, syringes, pulse oximeters, all the way to implantable devices like pacemakers. This would not be possible. And the scope of the issue is huge. Just looking at medical devices, we know that there are an estimated 2 million different types of medical devices on the world market. And these are categorized into 7,000 generic devices groups. Understanding which of these should be prioritized according to their risk and identifying alternatives will be a big task. Just to give you a little bit of background on WHO has various mandates. One of them, which our department is mainly responsible for, is to support member states with ensuring access to safe, effective health products that are good quality and that are affordable, accessible, and appropriate to those that need them. We also have an important mandate, which is mainly managed by another department. Some of my colleagues may be online with us today. That is to support member states in the understanding of human health implications of chemicals, waste, and pollution, and the actions that are needed to prevent harm. So these mandates go hand in hand with considerations for reducing, reusing, repairing, recycling, and proper disposal of plastics in healthcare while ensuring their access. So some of the specific actions that WHO is taking is that we are placing more emphasis on reusable health products. This implies considerations for reprocessing or sterilization processes in order to ensure their quality and safety and effectiveness. WHO assesses innovative technologies, particularly for low resource settings, and we publish a compendium where reusability is encouraged. And just an example of this is reusable sanitary napkins, which are manufactured in low-income countries. And we also encourage research on reusable personal protective equipment. In the search for new technologies, WHO publishes what we call target product profiles. These are used by manufacturers to understand the specifications of a public health need. And one example is the target product profile that was developed during the Ebola outbreak to support the development of reusable personal and protective equipment. WHO also publishes guidance on decommissioning medical devices. This supports waste management. We also publish technical specifications for procurement and reimbursement, and this provides important information to procurement offices on anything from reusable devices to sustainability criteria. So WHO also is advocating for ensuring funds for maintenance of medical equipment, and this is really important to support avoiding waste and discouraging repurpose of medical equipment and also of single-use devices, which are a growing problem in healthcare. In addition to the work that WHO is doing, we are working with partners. There's a lot more that needs to be done. We need the device industry to innovate in product design, to reduce our reliance on plastics that potentially, particularly those that may be harmful. We know that it's going to take time to find solutions and generate evidence to replace those plastics that are currently being used that pose risks. We need to engage with stakeholders to improve awareness and to increase understanding of the role in plastics in healthcare, to generate that evidence. And finally, just a statement on the treaty, which is happening. If any of you are involved, if we have people, member states online, we're really emphasizing that any provisions in the plastic treaty that could affect access to health products should consider the impact, especially for low income settings. And with that, I would like to thank the colleagues from the WHO Collaborating Center at the University of Toronto with whom we've collaborated to organize this webinar. And in addition, on generating some of that evidence that hopefully will be used. And now I'd like to turn over to Quinn, who will present the results of a systematic global evidence mapping project that we undertook last year as part of that evidence generation. In addition to leading the Collaborating Center, Dr. Grundy leads a program of research to understand the interactions between the medically related industry and health systems and their implications for sustainable health. Dr. Grundy, over to you. Thank you.
Thank you, Deirdre. Are the slides okay? You guys can see? Great. So as Deirdre mentioned, we've had the privilege of working closely with Deirdre and colleagues at WHO in this last year as WHO fulfills its role as an observer to the Plastics Treaty. I'm speaking here today on behalf of my team and colleagues, many of whom are here, and Navisha Weerasinghe and students who led this work. And this was funded by various initiatives at the University of Toronto. So as Deirdre has mentioned, as these treaty negotiations continue, some of the key areas for continued discussion include how do we make decisions not only about development of the treaty, but implementation of the provisions. There's talk of considering the precautionary principle. What role and what forms of evidence should inform these decisions? The idea that health impacts are obviously relevant across both the products and plastics life cycle. And the paradox that though many of our health products, their packaging can have health promoting and life savings effects, they also carry risks of toxicity and pollution. So all of this, I think, for us as a collaborating center focused on governance raises critical questions about how to promote access while addressing these harms. and how to support decision making. And so we decided to begin by asking, well, what is the evidence base that is available for us if we are to use evidence to inform decisions around governance across the health products and plastics life cycle? What health products and plastics ingredients have been studied, in what contexts? And then further, what outcomes have been measured? Certainly, there are health effects, environmental effects, but as Deirdre has mentioned, we also look at socioeconomic effects, the utility, and how these products are used in clinical and other settings. And so we sought to globally map a really diverse body of evidence to hopefully inform an actionable research agenda. Where are the priorities that would enable member states, other policymaking groups to act on treaty provisions as it pertains to promoting access to safe, effective, quality assured health products while addressing the harms of plastic production, use, and pollution? And so we sought to conduct a systematic scoping review to map the global evidence. We wanted to identify and characterize the research on the impacts of plastic and plastic ingredients, such as plasticizers, in health products and also their packaging. So Deirdre has mentioned the diversity of health products, pharmaceuticals, but also plastic is used extensively in the manufacture and also shipping, distribution of many of these products to maintain their integrity, quality, sterility. And we wanted to look then, are there patterns in the research agenda according to these characteristics? And to use this to describe some of the emerging research priorities that could inform equitable and sustainable governance of the impacts of plastics in this context. So we conducted a scoping review with no restrictions on date or language. We wanted to expand our view beyond the health sciences, biomedical disciplines. And so we searched databases that included engineering specific databases, social science, interdisciplinary, and biomedical. This was a very broad search, and we've taken a wide swath of very heterogeneous literature, and in the end included 572 articles that explicitly take up a marketed health product and or its packaging that was explicitly made of plastic or plastic ingredients. And we extracted any outcomes pertaining to the plastic health products and packaging, looking specifically for clinical, utility, socioeconomic, or environmental impacts, um, and identified this body of literature and then characterized it according to the outcomes and their life cycle. So I'll share kind of three key insights that came from this to set the stage for my colleagues' future discussions as well. So the first insight that we took is that this literature is very siloed by discipline and also the focus in terms of the health product life cycle. And so when I say life cycle, I'm referring to that process from when a health product is designed and manufactured through to when it is shipped or distributed, to the point of care where it is used, to when it might be sterilized, cleaned, maintained, through to its end of life, which includes how it is disposed, whether that is by recycling, landfilling, and then finally, when it decomposes in its final place. And so we found that the majority of articles on plastic health products focused on the use phase were conducted in high-income countries, primarily in Europe and the Americas, and were coming from health professional, health science, biomedical disciplines. So these would be clinical trials comparing a single-use plastic device to a standard of care silicone device. These would be articles looking at exposure from leaching or sorts of exposures from the use of IV bags, catheters, or other plastic devices. In contrast, though, the majority of articles looking at disposal, decomposition, were coming from low and middle income countries, and predominantly countries like China and India were responsible for publicly funding and producing a lot of this work. And the engineering and environmental science disciplines were very much focused on this end of life stage. We found very few studies that incorporated multiple stages of the product life cycle. Some of these are, representing life cycle assessment methodologies, but tended to be very siloed this way. So a second insight we found is that many of these studies are still focused on the challenges of managing excess plastic waste from health products. And since the global coronavirus pandemic, we saw really an explosion in research, particularly on how to cope with waste, personal protective equipment, face masks, and again with a focus in lower and middle income countries that are struggling with the waste management infrastructure. So we saw, though, a proliferation of articles and an interest in upcycling. So how to turn masks into concrete or asphalt or building materials, how to burn them, steam them, gas them. There are more technical terms for this. I am new to this field. But we want to offer that as a research agenda, the gravity of this plastics waste problem, its disproportionate burden on low and middle income countries, and the challenges of the waste management infrastructure, the toxicity of many of these ingredients suggest that we need some broader strategies and that perhaps a research agenda should also focus on prevention in addition to managing plastic waste. And so finally, I think what was surprising to me in our map, given that we had no restrictions on the date of publication, that there has been a decades-long concern around the leaching of plastics and their additives, primarily plasticizers, from health products and their packaging, and the impacts that this has on human and animal health, but also the quality and integrity of pharmaceuticals and blood products, and then finally the environment. So I have two charts here. We pulled out in the left-hand one the number of articles and the year and the focus on the plastic ingredient for medical devices. So you can see that over time, particularly for polyvinyl chloride and then its main additive DEHP, I'm not going to try to spell that out, has been ongoing for decades. And with the emergence of some regulation around these additives and a shift in interest to alternative plasticizers, we can see a bit of a shift, but a sustained interest. On the other graph, you can see the main plastic ingredient in personal protective equipment and masks is polypropylene, and really an explosion of interest in masks and their impacts as plastic products, but also a growing interest in microplastics and the leaching of these. And so I think for me, the takeaway here is that we can look at individual health products. We can even look at categories of health products. However, they will differ by market, by country, over time. And that perhaps these ingredients, these materials, is where the focus should be, and particularly in incentivizing and prioritizing research agendas that document and propose safe alternatives. So I'll leave just with a conclusion that we suggest a research agenda on plastics in health products needs to be life cycle oriented, prevention focused, and precautionary. So we need to understand what could be done to reduce the use of plastics in healthcare. We need to understand really both the health and environmental impacts in the context of the socioeconomic, the utility, these other considerations. But primarily that I think this calls for identification and assessment of safe, toxic-free, and sustainable alternatives in terms of materials and ingredients, and that this can be held accountable and made transparent throughout a product life cycle. So I will leave that here, and I will now turn over to my colleague, Dr. Nicholas Charters, who is joining us from Australia in his evening. He is Senior Research Fellow at the University of Sydney and has a large program of research around the commercial determinants of health with a focus on chemicals, fossil fuels, but also nutrition, public health. He is currently coordinating a program of work in collaboration with the Program on Reproductive Health and Environment at the University of California, San Francisco. But he has extensive experience in evidence synthesis. I learned a great deal from him on this mapping exercise, including the use of systematic review methods for the creation of guidelines. And so Nick has really been doing some important work in thinking about, well, we have an evidence base. How does this then support decision making? And so I'm going to turn it to you, Nick, to present your evidence to decision framework and what that could look like.
Thanks so much, Quinn. I'm going to cut my video and share my slides just for bandwidth. So give me one moment. Hopefully they're coming up in any second.
Great.
Looking good?
I still see the application, but we can give it a minute. It's not full screen just yet.
Let me try and swap. How's that?
I still see, there we go. You are good to go.
Perfect. All right. Thanks so much, Quinn. I'm just going to back a slide. So I'm going to start with this slide here. I am going to take you through a evidence to decision framework today. So I'm going to get quite deep into methodology, but I want you to keep this picture in your mind because really it's 5 simple steps that I'm going to be explaining, but it's going to get a little convoluted. Environmental exposures, including widespread industrial pollution, obviously impacts human health, and we know that they're amplified in more highly exposed communities. And currently, policy and regulatory frameworks for making decisions and recommendations on interventions to mitigate these exposures typically focus on a narrow set of criteria, and we currently don't have very transparent decision-making processes in environmental health. So this is why we developed the Navigation Guide Evidence to Decision Framework, which I'm going to take you through today and talk a little bit about and how potentially we could apply it in the context of plastics and healthcare products. Importantly, I did this work with a large group of collaborators across the US, and I'm obviously going to be presenting the framework on their behalf as well. And I just want to acknowledge all of the work they did. I also importantly have no conflicts to disclose. As many of you know, the World Health Organization estimates approximately 1/4 of all global deaths are attributable to environmental health harm, including chemicals, pollution, and waste, and they disproportionately impact low and middle income countries, as you can see here. This is largely due to fossil fuel, petrochemical, and plastics increasing exponentially since the 1950s. And you can see here on the slide that plastic production has increased dramatically since 2008. In fact, it's doubled, and it's projected to triple in the next 30 years. And I know most of you probably know a lot of these statistics. The largest source is single-use and packaging, followed by textiles and clothing. Other sectors, including tire, and pain and healthcare, sit at about 15 million tonnes per year. So they're huge contributors to the plastics that we have in our environment. As many of you would also know, there's a huge amount of environmental impact through the plastics life cycle, and we also get exposed via a lot of consumer products to toxic chemicals that are additives within the plastics themselves. And then also we get exposed to these degradation products, particles that we've learned a lot about. We've done a lot of research, our group, on the health effects of microplastics. And what's really important to take away from this slide is that there are numerous medical societies, government agencies, and systematic reviews that have concluded that exposure to the chemicals that are used as additives in plastics are known as endocrine disrupting chemicals. And these are really important risk factors for multiple diseases and health inequities, and contribute to a large burden of disease through temporal association. This is a huge concern because, as you can see here on this slide, that chemical pollution has now crossed the planetary boundary. We've got 350,000 chemicals registered for production use globally, and only a fraction assessed currently for safety. The other key issue is that methods currently used for assessing the risk of these chemicals are very limited in terms of their methods, and we still rely on a single chemical at a time evaluation, a single source for both exposure and also for hazard identification. Even when we are able to establish that a chemical is a hazard, like the one you can see here on the screen, which is phthalates, they're widely used in most plastics, also in medical devices, healthcare products, due to the flexibility it gives plastic products. We still are unable to regulate these contaminants across the globe consistently. And many of you may be wondering why. And a large factor in this is that the decision-making process that surrounds how we remove these chemicals and how we regulate them, historically in environmental health, has been one that is opaque. It's not systematic, and unfortunately relies still heavily on expert opinion only. However, evidence decision frameworks for interventions in clinical medicine and also public health provide a structure for decision making and include explicit considerations relevant to a decision context that you can see here on the screen. So on the top row there, you can see criteria that we went and looked at across a range of different frameworks that are used in clinical and public health for making intervention recommendations. And these are used by guideline development groups, panels that are responsible for making recommendations, and they're used to create structure and a way of ensuring that when the decision making takes place, that there is an underlying process that can be followed so we can determine how a decision was made. Unfortunately, as I mentioned, in environmental health, we still don't consistently apply this process. So we went about trying to understand what has been done in environmental health. This is a scoping review we did. We looked across a range of different frameworks. What you can see here on the screen on the right-hand side is a WHO framework, the WHO Integrate framework, which is an excellent framework. And while we thought that it was appropriate for multi-component interventions and really complex contexts, they didn't include important considerations for environmental health, such as the consideration of environmental justice. And so we identified that there's still a need to create a structured and transparent framework for environmental health decision-making, and I'm going to take you through that now. So just quickly on the methods, just so you can understand how we developed this framework. I guess the key focus was that we wanted to adapt and create a framework using the frameworks we'd identified, so things like WHO Integrate framework. And then we wanted to go and find key criteria that we thought were really critical for environmental decision-making and ensure that when decisions are being made, that they are explicitly considered and transparently documented in terms of how they are considered in that process. The way we went about doing this is that we organised a group of experts for a steering committee. It was a multidisciplinary committee of physicians, public health experts, environmental health experts, guideline experts from WHO, also from Cochrane. And then we sought feedback from a range of different stakeholders and end users. You can see some on the screen here, to ensure that the criteria that we were proposing were adequate, but also that we were able to capture, a broad set of perspectives, including community stakeholders, and that the guideline itself, the framework itself, would therefore be amenable for use across various different jurisdictions. So what does it look like? I just want to take you back to the example of phthalates for a second. So typically when we think about a chemical that's out in the environment and we want to understand whether it's harmful or not, like a phthalate, first step is to establish a study question. The second thing is to go and select the evidence, typically via a systematic review. And then there's a process of understanding or establishing the level of toxicity. And once we establish that something is toxic, we then have to go through this process of then, developing these intervention recommendations. So this is our framework, and I'm going to take you through a couple of these boxes just so you can understand how it flows and works. It's hard to do in 15 minutes, so bear with me. The first step is to apply the essentiality foundation, and I'm going to talk through this in a moment in a little bit more detail. And that is considered a framework foundation. It's a structural consideration that is asked or considered every time you go to evaluate whether a chemical should be regulated or not. You also then have to consider the quality of the evidence within the framework. So when you're making decisions, you need to systematically consider how much you can rely on the data that you're incorporating into that decision-making process. And a critical part of that is to consider industry sponsorship and study author conflicts of interest in the data. And then once that has been considered, we then want to systematically consider 3 key criteria to determine the right intervention recommendation. And you can see the 3 on the screen. I'm going to touch on these very briefly in a moment. The first one is environmental justice, and I'm going to define that. The second is maximizing benefits and reducing harms. And the third is social, cultural acceptability and feasibility of an intervention. So the foundation of essentiality, for those who don't know what it is, it refers to identifying whether the use of an exposure of concern, so think of a chemical, is considered essential for health and safety. The actual concept started or was first used or traced back to global discussions on how to restrict ozone-depleting substances, and the term essential use was later defined in the adoption of the 1987 Montreal Protocol. As you can see on the right-hand side, there are 3 questions that get asked about whether the chemical that's about to be evaluated or about to be have intervention recommendations developed for is essential or not. The first question is the function of the chemical necessary for the product or the use of the product? The second is the use of the chemical the safest feasible option? Are there any safe alternatives out there that we can actually use straight away and we don't need to continue to use this chemical? And number 3, is the use of the chemical justified because such a use in the product is necessary for health or safety for society to function? And you can answer the questions in any order at all. If you then decide that the chemical that has been evaluated, or again, thinking about health products, the product at a product level is essential, you then have to develop intervention recommendations. And you go back to the 3 criteria that I described before. The first one is environmental justice. This criteria is evaluating whether an intervention has the capacity to overcome historic and persistent disparities in environmental exposures, the risks and health effects based on social factors such as race, ethnicity, education, and income, among others, and to help reduce current health inequities within and across affected populations. So the intervention that you're going to develop and implement needs to ensure that you're reducing disparities in both exposure and risks. There are then sub-criteria and signaling questions and also other considerations, which I'm not going to go through now, but it helps essentially guide a decision-making panel determine whether an intervention recommendation is appropriate based on the criteria of this environmental justice criteria or criterion. The second criteria is maximizing benefits and reducing harms. And this evaluates the immediate and long-term benefits and harms of the proposed intervention. So if you're trying to, again, regulate a chemical, benefits include reduction of disease, increased quality of life, positive effects on the ecosystem and environmental quality, and economic benefits, both health and not health related. And the harms include all negative consequences from implementing the intervention. And this includes human and environmental health risks from implementing the intervention within and across affected communities and populations. Again, criteria, signaling questions, and other considerations are proposed to help guideline decision-making panels determine the appropriate intervention recommendation. The third and final criteria, before I give you one final example of the framework, is the criteria of social and political acceptability and feasibility. And this evaluates factors within society that determine the most culturally sensitive, acceptable interventions, which thus may be most effective and sustainable in the long term. And that involves a lot of community input around whether a proposed intervention is appropriate. And again, we have sub-criteria, signaling questions, and example considerations. So last 2 slides, what I'm going to show you here is a worked example of how we are currently applying the essentiality criteria to a chemical known as perchloroethylene. As Quinn mentioned, I work a lot in chemical policy, specifically focused on US federal chemicals and how they're regulated by the US Environmental Protection Agency. So this chemical is currently or has been evaluated by the US EPA. It's been determined to pose an unreasonable risk to human health. And it's currently going through risk mitigation, or there is actually a draft that's already been put out. And the process of this is that we've gone through is to determine whether the uses that it's been allowed for to continue in the next 5 to 10 years are what we call essential, and whether there are alternative chemicals that could take the place of this chemical that's known to be a human health hazard. So what I want to do is direct you to the top row of the orange box. And these are the three essentiality criteria that I described before. The first one is the function of PCE necessary for the product or use. The second is the use of PCE, the safest feasible option. And then the third one is the use of PCE justified because such use in the product is necessary for health, safety, or society to function. On the left-hand side are all the different conditions of use, or the way that the chemical is proposed to be used. And there's a list of around 60. I've only got 4 there for you. And so we've been going through each one of these uses that it's been proposed for, and we've been applying this criteria, and we found that it's not essential for almost everything. There is one use that we've identified that we're uncertain on whether there are safe alternatives for PCE at the moment, and that is processing as a reactant intermediate. So what happens in this instance? If a guideline panel essentially identifies that there is one use that may be in the short term essential, they do this. Before going on to make intervention recommendations using those criteria I described before, it's critical that they continue evaluating for alternative chemicals. So even when a chemical may be identified to be essential for a specific use, so if we're thinking about healthcare products, thinking about phthalates, there should be ongoing testing and development for safer alternatives for producing those chemicals. And if it's identified at any time, it's immediately incorporated into the product. The second thing is, if there isn't currently alternative testing going on, funding needs to be directed to the development of that chemical and finding alternatives to it. And the question of funding, obviously, is a really important discussion because the producers of these chemicals, and if it's known to be harming human health, should be responsible for finding those alternatives. Also, really importantly, is that strict timelines are set for phase outs. So if something is essential, that it's not a guaranteed ongoing use of the chemical. It's critical that there are timelines put in place for safe alternatives to be identified, and also to incentivize other companies to find those alternatives. Just finally, before I leave, this framework, as I said before, we are currently applying it. These are some of the skills required to operationalize it. I did it very quickly today trying to explain it. As I said, I know it was a little convoluted, but it does require a broad set of expertise because there are a range of considerations that are critical, across the impact to communities, obviously experts in environmental health, also guideline development. And when we're thinking about different jurisdictions around the world, legal experts will also be required. I'm going to stop there, and hopefully there'll be some questions after. Thanks so much.
Thank you so much, Nick. That was fantastic. As Nick said, we do invite your questions. There's the Q&A box at the bottom, so feel free to pop your questions in there. Speakers can then respond directly, or we can have some discussion at the end. I would now like to welcome Professor Jeremy Green, who's joining us from Johns Hopkins University, where he is the William H. Welch Professor of Medicine and History of Medicine and the Director of the Institute of the History of Medicine. And he has found his way to studying and exploring the ways in which medical technologies have come to influence understandings of being sick, healthy, on the regional, personal, global scales. His work has taken him in many interesting directions, from generic drugs and now to single-use healthcare products. He is a part of a global team that is exploring this issue and bringing social science and humanities perspectives to this. And today is going to talk about some of the work that they are doing around, again, how to make decisions about these products in the clinical settings and what we are up against. So, Jeremy, I will turn it to you.
Apologies.
Oh, you are muted. There you are.
No, thanks so much, Quinn, and Deirdre and Nick. It's such a pleasure to be part of this conversation, especially to the extent that we can engage this audience. I'm really interested in your questions and how this actually can help inform discussions leading up to the next step of the INC. As Nick introduced as well, I'm talking here as a single head in a small box in Zoom, but really I'm representing collaborative work by a number of individuals, and really an intersection of two different networks. One is the After the Single Use Project. It's an 8-nation study of trying to make visible but both the unseen costs and risks associated with single-use plastics after their single use, and also alternative means of actually rethinking sustainability in healthcare devices from their design and utilization as well in different parts of the world. And then also a related project, which has been called the Pass Up Project, a pragmatic approach to streamlining single-use products in healthcare. And representatives, I'm sorry, this is one of the problems of negotiating a shared screen in Zoom. I know people from both these networks are on the call, and I hope to join the discussion as well. A lot of my introductory material has been covered. There's a wonderful overlap here between our topics. But some of you may not know that around the world, some 16 billion plastic syringes are thrown away each year, 15 billion face masks. Deirdre pointed out that the bolus of excess healthcare waste that became visible by the COVID pandemic helped to spark many people who previously had not attended to this problem into beginning to think about how we attend to the ecological consequences of single-use healthcare devices. But even before the COVID pandemic, the WHO's Office of Climate and Health had already estimated that 1 out of 3 healthcare facilities in the world did not have the means to adequately process healthcare waste as it was produced. And some of the charts you've seen already document the exponential growth in single-use plastics as applied to healthcare, and the continued exponential growth in that site. So as a historian, as a practicing physician, I just want to point out, we've naturalized single-use products in healthcare. But these things were unknown in the first half of the 20th century. And medicine was modern even in 1950. But this global production, circulation, and disposal of single-use medical plastics has been taken for granted as a feature of modern medicine. We have a healthcare field that's deeply reliant on single-use plastics. We know that production, consumption, transportation, use, and disposal of single-use plastics contributes significantly to the oversized carbon footprint of the healthcare sector, which the Healthcare Without Harm report has documented. If global healthcare sector were a nation, it would have the 5th largest carbon footprint. Throughout the life cycle of extraction, refinement, use, ultimate disposal, plastics affect health in many different ways, some of which many of them have been detailed already in this panel. Most of the plastics in healthcare are not recycled. More than 90–95% are not recycled, fundamentally not recyclable the way that the system is currently formulated. And what I want to point out here is that disposability and discard is not merely tolerated in healthcare, but it's perceived as an inherent good. And it's that perception of the inherent and necessary good of throwing things away in healthcare that has greatly slowed ability to try to approach a more sustainable vision of healthcare. The Pass Up framework is a way to try and rethink these assumptions and think around it. And here's a photograph some of you may have seen before. It's a pro-plastics ad campaign during the Ottawa round of INC4 in April 2024, taken by a colleague. And if you look at these advertisements that appeared around buildings and hotels near the INC rounds, draws attention to the value of plastics in healthcare as a factor meant to mitigate the strength, to weaken the strength of a strong global plastics treaty. So single-use plastics certainly offer many benefits to those patients and providers who can use them as instrumental elements of care, thinking back of some elements of Nick's talk. And I want to think, for example, a synthetic plastic intravenous catheter in the moment of providing IV fluid resuscitation to manage an otherwise life-threatening state of cardiovascular shock. There are certainly health risks of the plastics involved, and yet the health benefits of receiving volume resuscitation during an otherwise potentially fatal moment seems fairly clear as a cost-effective balance. The trouble is that these benefits are easily marketed. SUPs also cause, single-use plastics also cause harms, especially after their use and discard. And those harms are not nearly as well marketed or evenly distributed. And so, as a local story, this became undeniably visible in my hometown of Baltimore just over a year ago when the Curtis Bay Energy Medical Waste Incinerator, this is the largest medical waste incinerator in North America, and it accepts medical waste from Canada as well. And it became the subject of the largest environmental crime settlement in the history of the state of Maryland, as it was burning excess volumes of medical plastics at subpar temperatures and emitting known toxins to surrounding community of Curtis Bay, a neighborhood that has the highest rates of pulmonary disease in the city and by some markers in the country. So beyond these harms caused in communities near sites of discard, medical plastics can have adverse effects on health throughout the life cycle of extraction and production. Plastics include additives, carcinogens, neurotoxins, endocrine disruptors that can have harmful effects on human health and the environment. There's a growing body of evidence that plastics and medical devices can fragment into microparticles and nanoparticles that can enter bloodstream and organs through infusion therapies, surgeries, and implants. Discarded plastics from medical devices contaminate soil and waterways and produce toxic fumes when burned, which was the key concern here in Curtis Bay. So these risks of exposure to chemicals and toxins during the production and discard stages of the plastic life cycle disproportionately affect low-income and disadvantaged communities globally and locally. So as a historian and physician, part of my job is to look at the way things are, the taken for granted aspects that are, how we do things in my clinic and hospital, and ask, why do we take this for granted? How did our healthcare system come to be this way? And do the logics that made sense at the time of its formation still hold in the present day? And I offer an image here at the center of a Plastipack BD insulin syringe, which was, the market leader in disposable syringes, and in many ways an iconic early single-use plastic medical device when introduced in the 1960s. And I point this out not to make BD as a company to be the villain in the story. It's a little too easily to create a narrative in which we look at a manufacturer as the problem. The plastic syringe that they began marketing some 60 years ago was a meaningful innovation. It helped many people. But history and ethnography help us to revisit the value of what we come to take for granted as necessary and offers an opportunity to collaborate at the intersection of many different sites. So here I'm highlighting this collaborative site between 8 nations, 8 cities, including anthropologists, historians, activists, and artists in Geneva, Edinburgh, Dakar, Oslo, Dar es Salaam, Hyderabad, Sydney, and Goroka, Papua New Guinea. And it's also an intersectoral collaboration in which we held convening conferences, including manufacturers as part of the solution rather than part of the problem, along with healthcare providers, purchasers, regulators, and consumer groups all have a role to play in reimagining a more sustainable approach to healthcare. So part of what I'd like you to take away historically is just to remember that single-use products were not always part of the modern healthcare landscape. Modern medicine had already for a century or so been built on precision tools built to last, and a circular economy in which every healthcare facility had the ability to safely and efficiently sterilize and reuse its own tools. It took skilled labor in essential supply portion to do so. Emergence of plastics in the healthcare field changed this equation, brought both optimism and also significant concern of potential dangers. If you look through, for example, I did a FOIA, Freedom of Information request from the Food and Drug Administration. Early correspondence between the FDA and plastic medical device manufacturers were full of concerns about what these additives, plasticizers, might actually do when in contact with human organs and human tissues, a conversation that was very active in the 1960s and then disappeared for a few. Here's an image from that same journal. This is a buying guide for hospital managers in 1958 about how to approach the role of plastics in the modern hospital as new items. But if you turn a few pages later in this issue of Modern Hospital, you find an advertisement also from BD showing that BD was interested in selling both disposables and reusables. So disposable products needed to be marketed to hospital managers and healthcare providers who initially didn't understand why disposability was actually helpful. Hospital managers, nurses, clinicians understood a circular economy of reusable tools. So what did disposable products do? At first, they turned labor problems, maintaining a skilled nursing force that could sterilize and sharpen things, into supply chain problems of how to get new objects in the door and then how to get old objects in the trash. And again, 1958, 1960, these decisions of just throwing it away made sense. The larger consequences, both on individual bodies and on landscapes, were not clear at the time. But since that time, single-use products have now become essentially associated with core values of healthcare in a way that makes them very difficult to disrupt, especially safety. So the global expansion of disposable single-use products in healthcare, especially in the 1980s and 1990s, was probably most visibly related to safety concerns surrounding transmissible diseases, first hepatitis, and then the new threat of HIV/AIDS in the 80s, which helped give rise to the emergence of universal precautions and the extensive use of single-use PPE. Disposable masks, protective gowns and gloves, syringes, IV bags, tubing, surgical drapes, devices like disposable blood pressure cups, catheters, and complex surgical instruments now form a huge landscape well beyond the disposable syringe of how we understand single-use plastics in everyday life. And I want to point out here that this contradiction, this sense that if one was to move away from disposability towards reusability, we would then be endangering the life of patients, forms an unacceptable premise for healthcare providers and healthcare institutions. In some cases, and this is true of Nick's formulation as well, in some cases, this is true. We know, for example, that the disposable syringe has helped reduce the transmission of infectious hepatitis and HIV/AIDS, right? So it's hard to imagine moving away from the disposable syringe. However, that premise then is used to universally apply to all single-use plastics, as if every single use of plastics in healthcare is now a necessary improvement in safety, which is simply not the case. Another core value of healthcare that single-use plastics has been aligned with is efficacy. And here you see another major disposable syringe leader, American Hospital Supply Company, with their new line of plastic syringes. And part of the marketing campaign around these syringes is that these needles are always sharp. Resharpening needles led to duller points. So if you get a sharper needle every time you open a new package, here you have a product that can be seen to be more efficacious. Moving back to a reusable product would be a reduction in that efficacy. And what patient wants to accept, what provider wants to accept, a less efficacious product. Similarly, disposable products have become associated with affordability. I'm listing the word efficiency here, but really comes down to affordability. And the premise here is related tightly to access. If healthcare is a low margin industry, across all countries, regardless of level of income, then anything that might make healthcare more expensive would reduce access. And so the problem of suggesting, well, it would be awfully nice to move to some more sustainable device, but if it's even a few cents more per product, that actually translates into fewer people being able to get treated. This then becomes a value collision. So what I'm highlighting here is that over the past 60 years, single-use plastics in healthcare have become associated with three of the cardinal virtues or values by which decisions of individual healthcare systems are made. And if we simply accept that this value conflict is there in all products, then we actually lose the ability to, we lose the ability to make progress in seeing where we can actually implement changes. So part of the problem here is that for any one piece of the value chain in healthcare, SUPs are now part of a local optimum. And I'm giving an example from the US health system, but in general, I think many of these apply in many places. If we look at sites of production, research and development, and manufacturers, see the potential markets for new single-use plastic devices. And this is partly why we continue to see the emergence of further and further uses of single-use plastics being developed in healthcare, even as we have increasing literature on climate and health risks. Further on down the line, if regulations of hospitals and healthcare facilities enforce codes for infection control that mandate increasing use of single-use plastics and plastic wrap, we continue to actually produce needs for all other parties to move in the directions. Hospital and purchasers and payers see single-use products as necessarily more affordable. So each of these sites in isolation see the use of a single-use plastic as necessary and unchangeable. So what we've been doing through the Pass Up Collective, we held an intersectoral consensus workshop last fall involving manufacturers, regulators, purchasers, clinicians, infection control officers, environmental advocacy groups, community organizations, to try and work together to find a common language of saying, when are SUPs necessary? I think this really comes back to the essentiality foundation that Nick is adopting in his framework as well. When do you need a single-use plastic product to achieve safety, efficacy, and affordability in healthcare? And when don't you? And when you begin to generate a larger universe, it turns out, yeah, unsurprisingly, a lot of what we think of as necessary is not necessary. And there's a lot of low-hanging fruit that's available for change. We know, based on audits that Healthcare Without Harm has done, that even the category of medical waste, only 15% of what is categorized as medical waste is specifically harmful based on infectious risk, chemical risk, or radiation risk, that 85% of what is thrown away is not necessarily any different or not necessarily harmful as medical waste. And most of this is single-use plastic packaging. So, for example, if a single-use syringe is actually something that has no acceptable safe alternative, there are other products like a single-use laryngoscope, which seems unnecessarily wasteful. There is no evidentiary basis that suggests a single-use laryngoscope is necessary from a safety perspective in the OR. If we think about questions of efficacy, there's many sites in which we can reduce plastic waste by asking, for example, at what point in the pharmaceutical shelf life of an expired pharmaceutical is it truly necessary to throw them away versus actually assess the possibility of extended shelf life. So where there is data for equal efficacy with less plastic waste, there are spots of possible reduction in single-use plastics. And similarly with affordability. So right now, a single-use plastic syringe is more affordable, right? But one can imagine a site in which further down the line, if actually enough volume actually develops, prices can come down for other products. And certain elements, for example, the use of disposable blue wrap in ORs, reusable blue wrap has been demonstrated to actually be equally affordable, if not actually cheaper, to use in key institutions than disposable blue wrap. So when we begin to develop a framework for assessing, and we've published this as a pragmatic approach to streamlining single-use plastics in healthcare and Annals of Internal Medicine just a few weeks ago. The point is that you can take any given potential area for reducing single-use plastics in healthcare and ask, is there evidence for a conflict with safety? Is there evidence of any difference in effectiveness? Is there evidence for any difference in affordability? And begin to accumulate for any one institution, where are there changes that can be implemented immediately? We're shifting from disposable to reusable blue wrap, reducing plastic packaging, shifting to reusable scrub caps, avoiding single-use blood pressure cuffs. You can also find these areas where there's a clear egregious conflict. For example, reusing hypodermic syringes. That's just going to be a no-go. But in the middle, we actually find areas corresponding to Nick's framework where this idea of switching IV antibiotics to oral forms, there's low risk conflict with safety. There can be a potential conflict with effectiveness. It really depends on the context. And in this case, it depends on the institution and the local institutional capacity, and it depends on a knowledge base, which is partial and opens up areas for further study, which again corresponds to the last element of Nick's framework as well. So we point this out because this is a way of translating how to move towards action that individual hospitals and healthcare systems in the United States and North America, around the world, can begin to think of immediately. We also think it can be built out into a more formal framework that can actually be implementable in this site as well. And this kind of rethinking, it can be implemented by single institutions, but it becomes even stronger as an intersectoral product if we bring different players to the table, and there are participants among manufacturers and industry, as well as regulators and payers and purchasers that want to come to the table for this conversation now. If each position in the healthcare field is unable to shift its reliance on single-use plastics alone, this coordinated action can help shape dynamics of the market to favor sustainable devices, to actually help create sustainable devices, and also attain the volume needed to make them affordable and in line with overall values of the healthcare system. And I want to point out, historically, for the first decade of the use of single-use plastics in healthcare, disposable devices were more expensive, not cheaper, than reusable devices. They only became affordable once there had been sufficient volume of use. So oftentimes affordability is not what drives the system initially, right? So it's concerted action of valuing products that allows them to then become affordable. I also suggest the pass-up approach. It doesn't deny that single-use plastics can save lives, but it also makes visible the lives that are threatened or harmed by single-use plastics as well. And it suggests that we need to stop seeing single-use plastics as a universal good in the field of healthcare, but rather as a field of choices that we need an evidence base on, and we need a clear framework to make decisions with. And that's the conversation that I'm excited to be in with you right now. And I'll end my slideshow here.
Thank you so much, Jeremy. What a fantastic note to end on. We're going to move into a bit of a discussion with the panelists and speakers now. I'm going to ask that if you can direct your questions, we have some coming in already. The Q&A box, if it is not instantly obvious to you, click on your More button at the bottom of your screen, your Zoom menu. That helps us to kind of have a moment to reflect and take the questions as they come. But I will invite Jeremy, Nick, Deirdre as well. Some questions coming in. And the first thing, a specific question actually for Deirdre that I'm going to then expand and invite the panel to comment on. We've talked a lot about the products themselves, medical devices, their ingredients, the use, but there's a question about what work WHO is doing on packaging waste, and this was particularly for medicine. But Jeremy, you've now talked about also the fact that most single-use items come in their own packaging. And I'll expand this because we have another question also around what our evidence map found around the use of plastics in manufacturing. And so I think manufacturing and packaging are two things we haven't talked a lot about just yet. But how might these similar frameworks, these considerations, what kind of evidence do we need to do? Are these same kind of decision-making processes applicable to the packaging phase, to the manufacturing phase? So I'm going to put that out there for comment, whoever wishes to jump in. I think, Deirdre, too, the question was around packaging specifically for medicines. But I think this applies to devices as well, especially for sterile single use. Does anyone? Deirdre, you want to start?
Well,
Sure.
just briefly, and then I'll turn it over to the other speakers. So WHO has a number of expert committees. We have specifically for pharmaceuticals, we have an expert committee on pharmaceutical specifications. And these committees work together to make recommendations, which WHO then publishes as guidelines, and they generally cover the life cycle of the pharmaceutical product. So we do have guidelines specific for pharmaceutical packaging, and those are currently undergoing review and will go to the next expert committee, which I believe is meeting in October, but I have to double check that. It could be the following year. Anyway, those guidelines are under review, and one of the considerations there for review and revision is the use of plastics in packaging to consider more sustainability. So that's one product that is relevant to the discussion. But the other, I'll leave the rest of the questions to the other speakers. Over.
Jeremy or Nick, did you want to comment on applicability of this to these other kind of phases?
I can jump in for a second, which is, and then I appreciate Deirdre's answer here as well. I think it gets at this question of, what medical waste is, right? And, medical waste doesn't really exist as a term till the 80s. And it becomes a heavily regulated space. And immediately afterwards, you see this problem. And it's the problem that generates this 85-15% split that Healthcare Without Harm is documenting, that actually most of what is being thrown away is actually just excess packaging. And that packaging itself shouldn't be considered to be, specifically medical device almost, right? And so it doesn't fit into the way that we actually see the overall regulation of medical devices, but it's contributing dramatically to the waste load. And I think that the challenge here comes in understanding the broad scale shift that happens. Not that sterilization is not a virtue in medicine, right? Like obviously sterile products and materials are essential to safe and effective healthcare provision, but that the location of sterilization shifts from individual facilities being able to do it on their own and understand the local impact of it, to it coming from afar in central sites. And then when it comes from afar at a centralized site, this actually added layer of packaging that both can actually make it through the transport phase, which is another, environmentally, weighty space through which carbon footprint of healthcare, increases. But that these part of the essential basis of these packaging products and why they're seen as essential to, safe healthcare practice is because that sterility needs to be packed into the commodity from the beginning, opened up. And so when we actually take a look at most of the packaging that is wasted and thrown away, these products it's not even necessary to insure that device, but it comes out of a broad scale culture, accepting that things need to come from far away, come in, and then be actually ready to use in a safe fashion.
Could I just jump in to follow up a bit on also what Jeremy was saying, that an important piece of the packaging puzzle is the regulation, we need to work with regulators to define this. And I was thinking specifically for as an example, vector control products, the mosquito nets that are generally there's a regulation that dictates that each net has to be packaged individually, and so that packaging contributes to an enormous amount of waste. So really the change makers in that case are those that are regulating the packaging so that alternatives could be found. Again, presenting the case to the regulators that alternatives to that type of packaging protect the integrity of the product.
Maybe, I don't know, do you want to respond to that, Jeremy?
Oh, just for a second, I totally agree. And I think even on like a international level, our local sustainability practice teams at Johns Hopkins have been identifying many areas in which we can actually guarantee a sterilization of an instrument, but that the Joint Commission's requirements then require that a single-use plastic be applied to this thing which has just been sterilized within the institution for use before it's used. So that there are many direct moments of unnecessary single-use plastics within hospital practice that relate directly to unnecessary requirements through hospital accreditors. And sort of bringing these regulators to the table and understanding how to align these goals is actually an important process of the PASS definition.
I'll build on that and then segue into another question here. In our work, we have also kind of, we think about governance in the pharmaceutical and medical device sectors, and we've looked at regulation. And at times, though, when we've dug into the policies or regulation, we'll note that there was a requirement for sterility or product integrity or something, but it didn't actually specify the use of single-use products, or it didn't specify the use of plastic. And when we dug into the literature a little bit, it turned out that the use of plastic was the most efficient and cheapest way to achieve the regulatory standard. And so we have a question here that really gets to price and cost. And so operationalizing these decisions, it strikes me, and I think our commenter here, David Renard, that some of these choices entail shifting costs. So Jeremy, in the example you've given about local sterilizing, that this includes a trained and skilled workforce that the institution pays for instead of purchasing, a disposable packaged product. Or David's comment is about balancing price of more sustainable alternatives within our tenders. So I don't know if you could comment within your frameworks if the economics have been considered. Also, then who bears that cost? And I would add my own question: is it an assumption that sustainable alternatives are always going to be more costly? So I'll put that over. Do you want to jump in, Nick? I don't know if did you have economic considerations in this?
Yeah, it's interesting. So, the way we've developed this framework was through the lens of US chemical policy. So we were thinking at a regulatory level where there is benefit cost analysis done. When we're thinking about the chemical, but the primary consideration in our framework, and we're thinking again at a population level, is that the benefits factor in not only the immediate short-term health benefits, but we're thinking also long-term, and then we also think about additional co-benefits. So when you have a narrow framing on benefits, when you're thinking about a benefits costs, and you think about what are the immediate benefits, so there could be reduction in disease, or there could be reduction in environmental exposures. It's important that they're not limited to now, and that that's factored in over decades. And then when we're thinking about the cost of an intervention, critically, the intervention itself is often put forward that the biggest cost is there's a potential threat of unemployment. There's an economic impact because you're taking a chemical out of a production line that is critical for not only the product itself, but a company is going to be impacted and their bottom line is going to be impacted. So I think it's really important when we're thinking about these that the quantification of benefits and costs are broad, but we also ensure that when they're done, that the analysis isn't necessarily done through the lens of the regulated community, and that there is an independent assessment done to this. A really good example of this is the Clean Air Act. It actually ended up being more cost effective, and it's created more jobs and been more economically beneficial for the US government year on year, even though the initial arguments that were put forward was that it was going to essentially threaten a lot of industries and cause all sorts of long-term consequences. So I guess they're my points, that we need to think more broadly about what are the benefits and the costs. We need to think long-term around the benefits. We need to think about co-benefits, and we also need to have independence when we're doing those analyses. And the regulated community isn't the one that's determining what those benefits and costs are.
Yeah. Jeremy, in your discussions, did cost come up in your multi-stakeholder, and in what ways is that being discussed?
Yeah, I think cost is crucial, but it's something we need to think about with a broader framework, right? So it's oftentimes raised as a reason why sustainability might just be sort of a pie in the sky idea, or wouldn't it be nice to have things that were less environmentally devastating, and yet because these are more affordable, and because healthcare systems run on such narrow margins, and increased costs then translates in a zero-sum game into reduced access, isn't it then immoral to actually insist on sustainability as a goal in a healthcare system? And I think that that's a tacit assumption that many healthcare providers have had for a while, and we really need to actively challenge it. So historically, we can challenge it by saying, hey, here's a disposable syringe. It becomes an incredibly affordable mainstay of healthcare. When it's introduced, it is more expensive. Institutions nonetheless find a way to prioritize it such that it then generates the volume capacity that allows the market for these items to become more affordable than the alternatives, which is to say markets are dynamic, right? The healthcare markets are especially complex, interlinked, systems that emerge from many different players that actively shape them. There's not sort of just some free marketplace in which these forces of supply and demand are simply meeting. So the real question is, if cost is a problem, what is the actual integration of values in the way that the markets are shaped that allows this to become the more affordable option?
I think also, we at WHO, affordability is such an important criteria for low and middle income countries as well, to be able to access products. And when we're looking at what makes a product affordable, we're generally looking at the cost of the product alone. We don't look at the associated costs of, a trained health workforce, or, the associated equipment that you might need, that goes along with that product. And so I think, going forward, understanding what would be the cost to replace one product by another that needs to take into account, maybe a trained workforce to sterilize products, or specialized equipment that hospitals may no longer have because they've moved to single use only. But when we're talking about cost, we're not talking about the cost of taking care of that waste. We're not making those comparisons. We're not making the comparison. What is the cost to human health because of these plastics? So, having a good model for measuring what is the impact of making a change, and making the case for making those changes when you're talking about affordability is going to be really, really important. It's complex. It's not a straight answer. If you pay $1 for a disposable syringe versus $2 for a reusable one, does that mean we should be going for the disposable one? How do we really make the measurement that is going to make a case for change?
So Deirdre, I agree entirely, and I think part of what's so interesting about looking at accounting is that hospital and health system journals were full of articles about how to make the cost benefit or calculus, how to do the right accounting, so that you could reckon when it was appropriate to shift to disposables versus not. And of course, this is a very conscious health economics deliberation about the shift that happened in the other direction, when to shift from reusables to disposables. But the reckonings had to keep on changing. What do you build into the model, right? And then even looking back historically, they're making good faith efforts, and they ultimately wind up making decisions based on the accounting portfolio that they build out at the time, which doesn't include any of the costs that we're talking about right now. They simply weren't visible on the horizon. So the point isn't to actually look back at these people in the past and say they did the wrong thing, as rather is to say, well, now that we actually know these other costs and we really need to take them into account, how do we build a system for responsible decision-making? So cost is essential, but cost is also, it's often wielded in a pragmatic sense of just, this is the world as it is, you have to take it for granted. Don't try to do something idealistic in a space where we just need to get by. And yet that actually oftentimes shut down really important decision-making. The other analogy I would give here, thinking with WHO Pharmaceuticals, is trying to understand the debates that happened in the very turn of the 21st century about whether antiretrovirals should be considered essential medicines because they were expensive.
Right.
And of course, we know antiretrovirals are essential medicines. And we were able to get to a point where alternative thinking about this, including the ways that the WHO tender process was mobilized, right, became a vehicle to help make them affordable. But the initial assumptions were antiretrovirals are expensive and as such can only apply to certain parts of the world. And thankfully, we were able to approach a lateral form of thinking and mobilize many stakeholders to get to a different place. I think we can do the same thing here.
Yes, and we have Kate Ludwig in the chat have also offered that maybe this requires alternative economic models, ideas like the total cost of ownership, looking at the entire life cycle of the item. We have a number of questions in these frameworks and their development, and Deirdre, as WHO carries on with the work, I think there is some really interesting questions about representation of different voices and stakeholders, particularly thinking about who is affected. And I think then the other side of that is this idea of differential responsibility, perhaps. And I think we've seen in climate policy this idea of common but differentiated responsibilities, and a principle that's wielded in a discourse in different ways, depending on your ability, capacity, impact. So Colin, Dorothy, Dr. Nat has asked for you to comment on your collaborations, particularly with Global North, Global South colleagues in your work. And then also representation of different voices. Nick, you've talked about impacted communities, but maybe specifically also thinking about workers and occupational health and exposures. So that's a gobble of questions. Maybe we can pull out some interesting threads there. So I'll open to whoever wants to jump in.
I'm happy to say very quickly that some of my collaborators, Alice Street from University of Edinburgh, Nandu Kishore from Hyderabad, Peter Mangesho from Dar es Salaam are here on this call, and I would invite them to jump in or jump into the chat if they can, because Peter's work, and it's early days for our collaboration, but Peter's work in trying to understand how the Food and Drug Administration works in Tanzania differently than the United States formulation or the UK. Hyderabad is an incredible site for thinking about reuse and thinking about single use in alternate formulations. And so, again, Nandu's work starting there is essential. So I think we need to acknowledge, right, that North-South power dynamics are a clear and present force to make explicit work against. And yet understanding sites of innovation that come from collaborators in Global South is absolutely essential. But I'll pass along to Nick or Deirdre to answer others.
Yeah, thanks, Jeremy. It's an excellent question. I'm thinking this through the lens of US chemical policy, but we've talked about how we can apply this to other jurisdictions. And I think a really important piece of our framework, I mentioned this idea of the distribution of benefits and harms, and ensuring that those that experience the greatest disparities in exposure and health risks are prioritized. And one of the key issues we have with chemicals and environmental exposures is that we don't have data. And so you often have communities, it could be in the Global South, it could be within countries in the Global North, where when you go to look at what are the health impacts, what are the exposures, because there isn't data there, because the government isn't measuring exposure levels, they're not measuring the populations over time, you rely critically on community voice and their experiences and lived experience to identify what are the greatest environmental exposures, what are the external stresses that they experience within a community that exacerbate the harms that they're experiencing. So it may not be the chemical, but they might be living in communities that experience high levels of violence or other things that are going to magnify and impact the community. So it's critical to have community representation. I had 10 minutes today to get into a framework that's quite detailed. We talk a lot about community involvement and how we're thinking about that at a US level. But I think as we try to test this and think about expanding it to other jurisdictions, I think it's critical, regardless of whether it's at the Global South or if we're thinking about occupational health, that there is that community or worker input.
Thank you so much for that. I am mindful of the time. We had many more questions, and I think could continue this conversation for hours. But this will not be the last conversation. I'll direct you to the chat where we have posted some links to the Collaborative Center for Climate, Health and Sustainable Care here at the University of Toronto, our co-hosts today. We will make this recording available on that website, but also have a series of seminars and workshops and other activities. We continue this work as a collaborating center and in partnership with WHO. Dr. Charters and Dr. Green, thank you so much for taking the time. Both of their frameworks are published, and we can share these links as well with the recording. But this is on the eve of the next round of the negotiation, so this hopefully is not the last time we have these conversations. Please do not hesitate to follow up with any of us directly if you'd like more information about the work. Our evidence map is under review. We hope to make a database of all these studies public and would love to work with any of you if you would like to do more focused evidence syntheses. There are many questions to be asked and answered. But thank you so much for taking this time out of your day to be there. Please join me in thanking the speakers and Deirdre for hosting. And we wish you all the best and look forward to continued conversations. Take care, everyone.